Good morning, everyone. I wish to thank Dr. Ramakumar for making a part of this instruction course. I'll be basically dealing with causes of anterior segment, that is, causes related to the cornea and the lens, which cause sudden vision loss. So coming to the corneal causes, I'll enumerate the causes first and then go into each of the cause in detail. So acute corneal edema, corneal aberration, corneal infiltrates and corneal melts, corneal hydrops, trauma. It could be blunt or penetrating trauma. In blunt trauma, usually because of corneal edema, you can have sudden vision loss, or corneal perforation leading to sudden vision loss. So what are the causes of acute corneal edema? It could be because of raised IOP. For example, in angle closure glaucoma, the patient reports with pain and sudden vision loss. Corneal aberration, for example, in recurrent corneal erosion, fingernail trauma to the cornea or any injury to the cornea leading to aberration, the patient can report with sudden vision loss. Certain types of corneal infiltrates, that is infections, for example, herpetic endothelitis, which is also known as disciform keratitis, can lead to acute corneal edema. Pseudomonas keratitis, which is a very fulminating type of a keratitis, which leads to ground glass edema, corneal melts, overnight corneal melts, can lead to acute sudden vision loss. Hydrops, which occurs in keratoconus and other corneal ectasias. Trauma, blunt trauma, the patient reports with corneal edema. Chemical injuries, chemical injuries because of acid and alkali, where a patient can have corneal edema, acute corneal edema. Coming to the lenticular causes, amongst the lenticular causes, the patient can have lenticular dislocation, IOL dislocation, and traumatic cataract. So these are basically the lenticular causes which can lead to acute vision loss, sudden vision loss. Talking about recurrent corneal erosion or corneal aberration, it is a disease. Basically, the patient presents with early morning sudden vision loss, acute pain in the eye, and blurred vision, and there is usually a history of previous ocular injury, history of fingernail trauma, and on examination you will see fluorescein staining. You can see a pseudodendritic pattern and surrounding corneal edema. Always look for a map.finger dystrophy, because usually in epithelial dystrophies the patient can present with recurrent corneal erosions. And how do you treat this condition? With antibiotics, lubricants. You can give bandage contact lens for almost 6 weeks, and that causes healing of the recurrent corneal erosion and strengthening of the basement membrane complexes. Also, superficial keratectomy has been described, and PTK. This is another patient with corneal aberration with surrounding edema. Certain kinds of keratitis, for example, pseudomonas keratitis, and like I mentioned, HSV, disciform keratitis, can lead to sudden vision loss with corneal edema. What are the risk factors of bacterial keratitis? Extrinsic factors, for example, prolonged contact lens wear, injury to the cornea, drug-related such as contaminated medication, prolonged steroid therapy, severe dry eye, poor tear film, neurotrophic keratitis, previous history of viral keratitis, systemic diseases, for example, diabetes, vitamin A deficiency. These are the predisposing factors for corneal infiltrates. So, patient basically presents with corneal epithelial defect, stromal infiltration, hypopyon, and lot of corneal edema. For example, in pseudomonas keratitis, which is associated with contact lens wear, it's a vision-threatening condition, and it requires appropriate management and prompt action by the physician. And it has a very worse visual prognosis. You can see here, this is a greenish hypopyon, ground glass edema of the cornea, epithelial defect, stromal infiltration, and corneal melt. So what should the ophthalmologist, general ophthalmologist, first responsibility be? He should scraping, things for grams, GIMSA, KOH, and culture, blood agar, Sabrod's agar, and chocolate agar. And come to a diagnosis. Before the results come, he should start the patient on fortified antibiotics, that is fortified cefazoline and fortified tobramycin. And if he suspects a fungal cause, then amphotericin drops or voriconazole drops can be started. Sometimes it is so fulminant that it does not respond to any antibiotics. So then perforation and melt ensues, and then the patient may require a therapeutic penetrating keratoplasty also. Eye drops. This is an important cause of sudden vision loss amongst the corneal causes. And there is development of edema, sudden onset of edema because of the break in the Descemet's membrane in patients with keratoconus and certain other ectasias like pellucid marginal degeneration. And here there is sudden onset of corneal edema because of seepage of the aqueous into the stromal cleft created by the break in the Descemet's membrane. And sometimes there is associated history of rubbing or trauma. And how do you manage such a condition? You can give antibiotics, lubricants, cycloplegics, mild steroids. Usually the edema subsides on its own in 2 to 3 months. Sometimes you can give injection of C3F8 gas to subside the edema, and usually in 4 to 6 weeks you can see complete resolution of the edema if you give intracameral injection of C3F8. This is an anterior segment OCT picture. You can see the intrastromal cleft, and you can see the aqueous which has seeped inside the stroma in a case of eye drops. So like I said, how do you approach for the management? Lubricants, antibiotics, cycloplegics, steroids. In 2 to 3 months you will see the resolution of the edema, but never plan a keratoplasty when there is eye drops. Always wait for the edema to resolve, and then once the scarring has set in, look for the amount of vision drop, and then you can plan further. So basically, these were the important causes, cornea-related causes. I'll be coming on to the causes for the lens. The dislocation of the crystalline lens is one important cause for sudden vision loss. How do we describe subluxation and dislocation? What is the difference between subluxation and dislocation? Subluxation is when the part of the lens still lies in the visual axis. It is called subluxation, whereas dislocation is when it is completely displaced from the visual axis, either floating in the vitreous cavity or lying in the anterior chamber. So then it is called as dislocation. So what are the important causes for dislocation of the lens? It could be trauma related, or it could be related to congenital disorders of the lens. For example, different syndromes like Marfan syndrome, Weil-Marchesani syndrome. So the patient presents with red, painful eye if there is history of trauma, decreased distance visual acuity, poor near visual acuity because of loss of accommodation. He could have monocular diplopia because the patient has phakic and aphakic zones if there is partial dislocation. So he will have diplopia monocular. Always determine if there is history of trauma. If there is no history of trauma, rule out possible systemic associations. For example, ask for history of any cardiovascular disorder because the patient could be having Marfan syndrome. Ask for any skeletal problems. It could indicate Marfan syndrome, Weil-Marchesani syndrome, or homocystinuria. Ask for any history of consanguinity, mental retardation, or unexplained deaths at young age, because the certain autosomal recessive disorders, for example, homocystinuria, hyperlysinemia, ectopia lentis et pupillae, or sulfite oxidase deficiency, these are associated with hereditary disorders. So basically, on examination, when you do retinoscopy, you will find both aphakic and phakic zones. Sometimes you will have myopia with astigmatism. Slit lamp examination will show phacodonesis or sometimes cataract. So the intraocular pressure could be elevated. What are the causes for raised intraocular pressure? Pupillary block, phacoanaphylactic or phacolytic glaucoma. It could be post-traumatic angle recession if there is history of trauma. Or the lens could be in the anterior chamber leading to raised intraocular pressure. Dilated fundus examination to rule out retinal detachment is very important here. This is a case of Marfan syndrome. Here you can see superotemporal dislocation of the lens. Weil-Marchesani syndrome with microspherophakia with inferior dislocation of the lens. Traumatic cataract, again, this is an important cause for sudden vision loss. If the patient has penetrating eye trauma, usually there is cortical cataract and sometimes the lens becomes cloudy very fast. And if it is a blunt trauma, then the patient often has this picture, that is rosette-shaped cataract. So ask for any history of trauma if you see such a picture on slit lamp. This is typical rosette-shaped cataract. And this is on retroillumination. Here you can see the rosette cataract. So when do you intervene? If there is not much loss in the vision, the intraocular pressure is controlled, the eye is not inflamed, then you need not intervene in such a case because of blunt trauma if you see clouding of the lens. And you can try medical management in case there is increased pressure, there is uveitis. You can try miotic or mydriatic therapy. If the cataract is partially in the visual axis, sometimes the miotic therapy works. So basically, when do you, these are the indications of surgery. When there is inflammation, when there is raised intraocular pressure, when the vision loss is severe, then you have to intervene. You can either go for standard phaco, you can go for ICC or pars plana lensectomy and vitrectomy. You can refer the patient to your VR colleague. Here the help of the VR surgeon could be required if there is a lot of dislocation of the lens, subluxation, then you might need to take the help of your VR colleague. So when do you do capsular fixation? If the zonules are intact and the PC is intact, do capsular fixation. You might need CTR when the amount of zonular dialysis is less than 180 degree. You might need to do sulcus fixation if the PC posterior capsule is ruptured but the zonules are maintained. Or you might need to do a scleral fixated IOL. Sometimes you might need to leave the patient aphakic. IOL decentration is an important cause because of posterior capsular rupture or zonular dialysis. There could be history of trauma, history of yak capsulotomy. So this is the picture you will see on slit lamp, a dislocated lens. And the patient will complain of halos, glares, double vision, another dislocated lens. Patient could have associated retinal detachment, cystoid macular edema, vitreous hemorrhage, along with the dislocated IOL if there is a complication intraoperatively. And a VR surgeon should be consulted whenever you have a dislocated IOL. Thank you very much. So I hope you have benefited from this presentation.